Which of the following does not indicate unfavorable outcome after CPR? A. Lactate levels below 2 millimoles per liter. B. Unwitnessed cardiac arrest. C. pH less than 7.2. D. Initial rhythm other than ventricular fibrillation. Correct answer A. Lactate levels below 2 millimoles per liter. Most frequent manifestation of acute coronary syndrome: A. ST elevation myocardial infarction. B. effort angina. C. Non-ST segment elevation acute coronary syndrome. D. None of the above. Correct answer C. Non-ST segment elevation acute coronary syndrome. Non-ST segment elevation acute coronary syndrome can be further subdivided into non-ST segment elevation myocardial infarction and unstable angina, depending on whether biomarkers of myocardial necrosis are elevated or not. The prognosis is poorer if biomarkers are elevated, indicating need for early invasive strategy in management. Investigation of choice when the probability of coronary artery disease is more than 85%. A. Invasive coronary angiography. B. CT coronary angiography. C. Stress echo. D. Nuclear imaging. Correct answer A. Invasive coronary angiography. CT coronary angiography and functional imaging studies like stress echocardiography, nuclear imaging, stress MRI, or PET perfusion imaging are indicated only in those with intermediate probability of coronary artery disease. Intermediate probability is considered as probability between 15% and 85% in this case. In those with a low probability below 15%, CT coronary angiography and functional imaging studies are not indicated. Type 2 traumatic aortic injury is A. Intimal tear. B. Intramural hematoma. C. Pseudoaneurysm. D. Rupture. Correct answer B. Intramural hematoma. Type 1 traumatic aortic injury is intimal tear. Type 3 is pseudoaneurysm and type 4 is aortic rupture. Traumatic aortic injury is the second most common cause of death after brain injury in cases of blunt trauma. On-site mortality is around 80% for traumatic aortic injury. Most important cause of blunt traumatic aortic injury is sudden deceleration, as in a motor vehicle accident or a fall from a height. Torsion and shearing forces causes maximum injury at the relatively fixed portions of the aorta like aortic root, region of ligamentum arteriosum and the diaphragm. Injuries may be noted at the aortic isthmus in 90% of cases. 48-hour mortality in unoperated acute type A aortic dissection: A. 25%, B. 50%, C. 75%, D. 90%. Correct answer B. 50%. Treatment of choice for acute Stanford type A aortic dissection is surgical, although endovascular treatment has been tried in certain cases. Even with surgery, perioperative mortality is around 25%. Neurological complications can occur in about a fifth of type A aortic dissections. Surgery for type A aortic dissection has been shown to reduce the 1-month mortality from 90% to about 30%. Predictors for postoperative mortality in Stanford type A aortic dissection: 1. Pericardial tamponade with shock. 2. Stroke and coma. 3. Malperfusion of coronaries or peripheral arteries. Example, mesenteric malperfusion with bowel ischemia. Anisosphygmia is an important feature to look for in suspected aortic dissection. What percentage of persons with aortic dissection have anisosphygmia? A. 30%, B. 50%, C. 70%, D. 90%. Correct answer A. 30%. Anisosphygmia or asymmetry between the peripheral pulses occurs in about 30% of those with Stanford type A aortic dissection. It is around 15% in those with type B aortic dissection. Though anisosphygmia is a typical finding of aortic dissection, it will not occur if the dissection flap does not involve the ostia of the aortic arch branch vessels or the iliacs. Most specific feature of pain in aortic dissection: A. Abruptness of onset, B. Location, C. Radiation to back, D. None of the above. Correct answer A. Abruptness of onset. Abruptness of onset of severe chest pain with or without radiation to back or pain in the back is the most typical feature of aortic dissection. Nature of pain may be tearing or sharp and different from other causes of chest pain. Chest pain occurs in 80%, while back pain occurs in 40%, and abdominal pain occurs in a quarter of patients. Chest pain occurs more often with Stanford type A dissection, while type B dissection causes pain in the back or abdomen. Blind spot for transesophageal echo for aortic imaging: A. Proximal ascending aorta, B. Distal ascending aorta, C. Proximal descending aorta, D. None of the above. Correct answer B. Distal ascending aorta. Distal ascending aorta just before the innominate artery is difficult to image with transesophageal echocardiography because of the intervening right bronchus and trachea. Rest of the thoracic aorta, including descending thoracic aorta from left subclavian to celiac trunk, can be imaged well by transesophageal echocardiography. Both short axis and long axis images are possible by multiplane TEE. True regarding D-dimer assay in venous thromboembolism: A. Positive D-dimer assay has a high positive predictive value. B. Negative D-dimer assay has a high negative predictive value. C. ELISA-derived assays have poor diagnostic sensitivity. D. None of the above. Correct answer B. Negative D-dimer assay has a high negative predictive value. A negative D-dimer is useful in excluding venous thromboembolism. Studies have shown that 3-month thromboembolic risk is less than 1% in those left untreated due to a negative test. But a positive D-dimer assay is not useful in diagnosis, as many conditions like bleeding, trauma, surgery, and cancer can cause elevated D-dimer values. ELISA-derived assays have a high diagnostic sensitivity of 95% or more. Please don't forget to subscribe to this channel for future updates and click on the bell icon for all updates. Thank you.